This is the Fix Your Sciatica podcast. And we are back talking about the various different medications that can be prescribed for issues like sciatica and low back pain. And today's guest is a pharmacist. Been interviewing other pharmacists because they're the masters on the chemistry and the understanding of how medications work. And I thought it'd be a great opportunity to have today's guest talk a little bit more about one of the medications that he finds a particular interest in, which is going to be muscle relaxers. What are they? What do they do? And how can they help us? So today I have Dr. Sonny Shah, pharmacist. Sonny, so good to see you.
Hey, thanks for having me on, Ashley.
Yeah, so let's talk about, before we go into the drugs themselves, I always get introduced to pharmacists through some really great connections, and I really appreciated your background and your desire to help people. So for the listeners who haven't quite heard your name, can you tell us a little bit more about yourself and the journey of where you're at today?
Yeah, sure. So I've been a pharmacist since 2015. That's when I graduated pharmacy school. Went right into community setting, retail pharmacy. I come from an independent pharmacy background and currently am working in a community chain. And what I really like to do is create relationships between patients and myself. So that increases care, better outcomes, and more customer satisfaction. That's what we really want at the end of the day. And as of recent, I've been looking into getting into pharmacogenomics and nutricogenomics testing for patient compatibility. So it's a very new and upcoming frontier.
Pharmacy is such a fascinating profession because, one, I mean, yes, it's part of the medical profession, but from a chemical standpoint, you have the understanding of the breakdown. You can go into, say, big pharma, which is like medication development. You can go into research. You can also go into, say, the retail pharmacy, and then definitely looking into the pharmacogenomics, and then I think you said nutrigenomics as well. Is that right? It's really cool to be able to see the versatility of it, because I remember coming up as a physical therapy student, I remember just thinking, all right, well, pharmacists are just the people who distribute the pills at the pharmacy that I go to. And I even remember going through the hospital rounds, which I was actually surprised that as a physical therapist, I would go do hospital rounds. It wasn't something that we were often a big part of. And so it's exciting to interact with more and more pharmacists and the really cool knowledge. And you're absolutely right. Being able to have a good relationship with your neighborhood pharmacist gives you a huge understanding of the medication that you're having or you're using and what are some of the things to consider, which is why we're on today's episode, is to be able to discuss the medical class of muscle relaxants. I think that it often gets prescribed when people are experiencing pain. And I've always been so interested in regards to why this would be prescribed in the first place, but also the scientific or the physiological mechanisms in which these medications work. And so, Sonny, if you can, tell us a little bit more about muscle relaxants. What are they specifically? Like, how would someone know that they're on a muscle relaxant itself? Like, what are some of the names?
Yeah, sure. So muscle relaxants have been around for probably since the 50s and 60s. That's when they really were pushed through like drug industry. But as early as I think there was an Amazon tribe that they would dip their arrows in I think this poison. It was a muscle relaxant. I'm forgetting the name of it right now. But they used to use that to paralyze invaders and such right off the arrow. So it's been, used throughout history. But as of like the last 60, 70 years, that's when they've manufactured them. So this class of drugs can cause the relaxed skeletal muscle in various ways. And I'm going to go into what sorts of ways they are. But they address two types of muscle issues. You got stiffness or spasticity. Those are caused by MS, cerebral palsy, spinal cord, brain injury. So that's one type of muscle relaxant class. But we're dealing with the twitching or spasms type of muscle issues that muscle relaxants deal with. Then, of course, it addresses sciatica, herniated discs, or spinal stiffness. So these are the two main classes of muscle relaxants that we're dealing with. And a couple of the names that patients might know of are like Flexeril or cyclobenzaprine, Robaxin, or methocarbamol, and another one called Scalaxin, or that the generic name is Metaxalone. So those are the three main ones we'll focus on today.
Love it. Yeah, really interesting. I find it so fascinating that, say, a chemical like this was actually used back in the day as a weapon. And I think I remember, I don't know specifically, well, maybe I think it's like tetrodotoxin or something like that. I have no idea. But anyway, it was like these, down in the Amazon, it was like they called them poison hour frogs. They were like, I've seen pictures, they're like lime green, really cute, but you definitely do not want to touch them because that is a dangerous thing. Also really cool to be able to talk about the mechanisms, that there's two specific categories. You were talking about spasticity, which often happens with, say, MS, and usually when I look at MS, and I missed the other conditions, but we're looking at more of like the central nervous system, how the brain and spinal cord interact with what we call your peripheral nerves. And then the second class is the spasms and stiffness, which is really more of what we're looking at, like muscle physiology, but then also the peripheral nerves. So pretty much, listeners, in previous episodes, we've talked about the various different aspects of the nervous system, and we have two pieces of the nervous system. We have what we call our central nervous system, which is going to be your brain and your spinal cord. And then we have your peripheral nervous system, which is the nerves that actually exit your spine. And so when it comes to, say, treating something like sciatica, we can either look at, okay, well, what is happening with the central nervous system? Is it something that we're processing in our brain? But also, is there actual spinal cord compression that is leading to improper function of the nerve itself before it actually exits the spine? That's the central aspect. And then we look at the peripheral nature of sciatica pain, which is going to be the moment it actually exits the spine. And that's where we're looking at possibly even some neuroforaminal narrowing, or even some tight muscles, say like piriformis syndrome and everything like that. So it is important for you to either work with your practitioner or discover upon yourself, is the pain that I'm dealing with, is it actually something because of my back, or is it deep in my back, my spinal cord, or my brain? Or is it something related to the moment that the nerve exits my spine? And that's where we're looking at peripheral aspects. And that will actually dictate what exercises you need to do, but also it can help the clinician understand what medications could be particularly useful for that. And so, Sonny, I think you listed 3 different medications. I've heard Flexeril a lot, and I see that prescribed a lot. So if you can, when you briefly talked about the various different mechanisms, would you be able to break down some of the cool chemical processes that happen as a result of taking these medications?
Sure. Now, Ashley, I don't want to disappoint you, but a lot of these muscle relaxants, their mechanisms are still unknown. So there are some hypotheses, but they actually still don't know why they work and how they work. But Flexeril, it's actually chemically, like structurally similar to a tricyclic antidepressant called amitriptyline. And it works, so not only cyclobenzaprine, but the other two, the methocarbamol and the metaxalone, they all work to depress the central nervous system. And the depression of the central nervous system through these drugs, it's thought to lead to the relaxation of the skeletal muscle. So that's like the general hypotheses of how these drugs work in the body. I wish there was more like juicy chemical details, but that's really all that they've put their knowledge into. And since these drugs have been on the market for so long, it's not like they're going to do any more research into what the actual mechanism is anymore. It does it, so they just go forward with it. That's basically where we are at this point.
This episode is brought to you by the Patient Advocate Program. Are you tired of not having support between your rehab sessions? Introducing the Patient Advocate Program, and we're focused on your recovery, and we're offering you 24/7 access to a doctorate of physical therapy. Stop waiting in line to be seen and stop spending hours doing long exercise programs. Imagine being able to get all of your care delivered straight to your phone. Best of all, it's affordable. We believe everyone deserves top-notch relief without breaking the bank. So why wait? Take control of your health today and visit ptpatientadvocate.com and book your free call with our experts. Well, I really appreciate the reality that you brought to the light. I think it's really easy and especially you'll see this in pharmaceutical marketing. They're going to create like this crazy, amazing, beautiful diagram, and you're looking at it thinking, okay, yeah, this is going to work. But One thing that you did bring up, which I found to be extremely fascinating, was that it actually acts on the central nervous system, which we're looking at brain and spinal cord itself. So it was central nervous system. So brain and spinal cord, which in my head, if I remembered correctly, if we're affecting the central nervous system, we actually have to have chemicals that actually cross the blood-brain barrier. Is that correct?
That's correct. Yeah.
Yeah, and so listeners out there, the blood-brain barrier, the way it works, and I'm just going to share the anatomy, but perhaps, Sonny, if you know a little bit more about how things kind of get transferred, the blood-brain barrier, so pretty much your brain and your spinal cord are sheathed, covered in this connective tissue, which is called the dura mater. And the dura mater is actually like a thick leather sheet, and it protects your brain and your spinal cord from a lot of different forces. But as you know, or as you may or may not know, there's actually what we call cerebral spinal fluid, which is the fluid that kind of surrounds your brain. Also, it surrounds your spinal cord. And when you are, say, getting a cortisone injection, an epidural injection, they're actually going into that specific area, which is why if you ever get back surgery or even an injection, they want to make sure that you keep that specific area clear, because you don't want to get that specific area dirty. Now, the central nervous system, we have to cross the blood-brain barrier. So, Sonny, if you can, tell us a little bit more about, and I'm going to take a step back, these muscle relaxant medications.
Right.
Are they usually ingested in pill form, IV, topical patch? What are the common ways that this is consumed?
So generally what we see is an oral tablet. They're orally taken. Rarely have I seen them injected, and most likely they'll probably do that in the like a hospital setting or such. But these medications, these common ones, they're given orally.
Okay, yeah, that makes sense. And so, from your knowledge, Sonny, like once the pill gets ingested, what are some of the pathways, or if you recall, because I kind of have a basic knowledge about like what's the process like that goes into their stomach and it gets absorbed. Would you be able to share us what that journey could look like?
Sure. So obviously when you take it in, it's going to go right into the stomach, and then through the stomach and through the small intestine, it's going to be absorbed into the bloodstream. And a lot of the medications, I don't know if it's been addressed before, the bloodstreams lead right into the liver. And the liver is the first point of metabolism or clearing of the, any sort of foreign substance medications, chemicals that you've ever taken in, they go through the liver first to be processed. Depending on the drug, we have some drugs called prodrugs where the liver, actually prodrugs that are actually inactive, and when they get absorbed and through the liver and they get metabolized, they become the active form. Those are some drugs. There's a good amount of them on the market, but a majority of the drugs that we take are active when they go in, and the liver will inactivate them or can metabolize them to a point where their metabolite is also an active metabolite. So we have those kind of scenarios. And so once it passes through the liver, it now enters the bloodstream. So through the bloodstream, it can cross into the blood-brain barrier. It go through the blood-brain barrier depending on how fat soluble it is. The higher the fat solubility, the more likely it'll pass through the blood-brain barrier. But the more water soluble it is, it has a harder time going through. But basically, it goes through, it acts into the CNS, the central nervous system. It'll have its action there, and then usually we'll see with these muscle relaxants, you'll see it work within 30 minutes to an hour or two. That's when you'll first start seeing the effects of those medications, and they last anywhere from 4 to 6 hours to anywhere 12 to 14 hours. That's like the general half-life, or like the time it takes for half of the active ingredient to be eliminated from the body. And some are eliminated through the liver, and another majority of them are eliminated through the kidneys. So I'll touch upon which ones you can't take if your liver's not doing so well, if your kidney's not doing so well. But yeah, we'll talk about that in the future.
Yeah, it's really fascinating. And so the medications we take, they go through a pretty thorough process. I don't know the exact mileage, but if you were to take all the blood vessels in your body, it's a very long distance. And so the drugs themselves go through a lot of different processes, has to go through and get processed in the liver, and has to cross that blood-brain barrier. And thank you so much for sharing like the amount of time it takes for this medication to be into effect, because earlier in this episode, you were talking about how I think the Flexeril is very similar to tricyclic antidepressants, which is actually an episode that we had a few weeks ago. And usually with tricyclic antidepressants, in that episode, they talked about how it actually takes a little bit longer for that medication to take into effect. I think for them, it was a couple of weeks as compared to, say, something like this, where it actually takes, I think you said 30 minutes to an hour. So it's really interesting to see that. And the effectiveness will actually depend on, I think you said it's depending on the chemical itself versus the actual dosage. Is that right?
Yeah.
Okay.
Exactly.
Yeah. And so since it actually acts on the central nervous system and causes relaxation, are there any side effects or other effects that happen when taking this medication in?
Yeah, sure. So anytime we're dealing with the central nervous system, and in this case, we're causing a depression or slowing down of the central nervous system, we're always going to see common side effects like sedation, dizziness. You're going to see a fall risk in elderly patients. So you want to watch out. You're over a certain age to not be taking it. With the cyclobenzaprine, like I said before, it's like a tricyclic antidepressant. You're going to watch out for patients who have already been taking antidepressants, an older class called MAOIs or monoamine oxidase inhibitors. It's like an old school type of medication. So with that, you're going to have increased amount of serotonin, and the increased amount of serotonin causes a syndrome called serotonin syndrome, where you're going to have like rapid heart rate, blood pressure is going to hit the roof. Sometimes it can cause as worse as like seizures and such. So you got to watch out for these kind of interactions or side effects with the medications. In patients that are going to be started with the cyclobenzaprine, they suggest that if you're already taking an MAOI, antidepressant, that you wait at least 2 weeks until after you actually stop the MAOI to start taking cyclobenzaprine. That's how strong the evidence is with that interaction. And that's just cyclobenzaprine. You also want to watch out for patients who have any sort of cardiac conditions, so like arrhythmias, heart block. I would say just avoid cyclobenzaprine if you have a heart condition. Not the greatest medication to take. There are alternatives, obviously the other two that I have, but cyclobenzaprine definitely stay away from in that case. If I talk about methocarbamol, you want to avoid that in patients with epileptic disorders because it can lower the seizure threshold, which essentially means anything that if you have like seizures that are triggered by certain things like flashing lights or anything like that, in patients who already have epilepsy, methocarbamol is going to cause a seizure quicker. Also, you're going to look out for either brown, black, or green colored urine with methocarbamol. That's a common side effect. I know that if you see yourself producing green urine, you're gonna jump off the wall thinking it's like you're straight out of a Dr. Seuss book. But that's a general side effect. Nothing to be concerned about, but it is a normal side effect. Then with the last drug, the metaxalone, that's relatively all right with the dizziness and the drowsiness side effects. So if you were to use that in elderly patients, that's fine. But the only thing of note is that you cannot use scalaxin or metaxalone in anyone with severe kidney or liver impairment. So those are like the main side effects you're looking at with these drugs.
That's really important. I think it's really easy for people to go in and get prescribed medications right from the get-go and not really quite sure, especially if you do have a pretty complicated medical history, to be able to figure out, well, how can I balance all this stuff? And when it comes to the side effects, the sedation, dizziness, it's like we're looking at relaxing your muscles. And unfortunately, with medications, when you are taking, say, a pill, you're going to be looking at general muscle relaxation. It would have been great if it was much more localized. Often the localized relaxations will often be done with more localized or pinpoint interventions such as injections. And there are some acupuncturists as well as physical therapists who actually play in the use of dry needling, which is a very localized input. And so thank you so much for sharing a lot about the side effects, but also the interactions that people really need to consider given their medical history as well, and especially the urine. I know that any change in urine is always a scary thing, and it's actually something that I do ask the patients and clients that I work with in regards to just understanding hydration, but also listeners. I had an episode a while back talking about how I didn't diagnose kidney stones, but I actually helped suspect kidney stones in a person who was dealing with a lot of pain, and we were able to get that addressed just from a couple specific questions, which is why it's important to ask questions or answer as many questions as you can with your provider to the best of your knowledge, because we can get the necessary information to provide you the best information for you. Sonny, this is really eye-opening. It's huge. I remember seeing patients and they were prescribed these medication, muscle relaxants specifically, and the general consensus that people got when they got prescribed these muscle relaxants is that it didn't make them feel very good. They were getting tired. Like, it in some cases didn't necessarily affect their pain as well. So when I was actually being presented with these scenarios, I was thinking, well, why would patients be given this medication in the first place? And so the class of these medications, which is muscle relaxants, does exactly that. It relaxes your muscles. And so it makes me think, okay, well, why do we need muscles to relax in the first place? And I think oftentimes it's because when you're dealing with pain, we can be suspecting a possible muscle spasm, and that muscle spasm itself needs some sort of way to relax. And so there's a lot of different mechanisms when it comes to muscle spasms. You have your central nervous system, which is stuff like MS and spasticity and stuff like that. But then also from a cellular level, what's really interesting is that our muscles, they're relaxed, but they have a little bit of tone. There's going to be kind of like an electric current going through them. And if you send enough electric current to that muscle, it'll actually contract. It should contract and relax. That's a normal process, a normal function of a muscle. But if a muscle contracts, but it continues to contract so much, it can actually hit this level of what we call tetany, or tetany, which means that it's a sustained contraction. And that is where things start to become problematic. It's painful. Try to hold a muscle contraction for a long period of time. You're going to burn. It's not going to feel good. So I understand why this would be scheduled in the first place. But what's really interesting, especially when you're dealing with sciatica pain, it's often not really a result of a muscle spasm. And oftentimes when I find muscle spasms in the back, they often happen because people are using their back muscles too much. You're trying to use your back to do the specific option. So of course it's going to spasm. So that tells us we have to use our hips a little bit more. Before we actually started recording, Sonny, you were talking about a really interesting fact about these medications, about how it's really geared towards short-term use versus chronic use. So can you shed some light on what you were saying before?
Yeah. So generally, these muscle relaxants, surprisingly, they're not even first-line treatments either. Studies have shown that they're not better to treat like anything like low back pain, sciatica. They're no better than using an NSAID or an ibuprofen or something like that to treat for that pain. But if the patient doesn't find any relief with taking NSAIDs, then muscle relaxants are short-term use drugs only. Should only be used for a maximum about 14 to 21 days, and anything beyond that is worsening for the patient. They're going to be chronically drowsy, chronically dizzy. There are a lot of side effects or interactions with if you're on anything else that causes dizziness, like opioid pain medications. Now that's that interaction is a red flag. Prescribers shouldn't be prescribing them together, nor should another prescriber prescribe muscle relaxant without looking at the patient's prior history or current list of medications. This collaborative practice in healthcare needs to be addressed more, needs to be looked at more. And the pharmacist almost feel we feel like we're the middlemen in everything. Every prescriber that prescribe something for the patient, we're seeing as they say, all roads lead to Rome. I feel like pharmacies are like Rome. We see everything that the patients are taking, and we'll generally see that physicians don't talk to each other or don't inquire about patients. And these patients, unfortunately, they are burdened with so many of commonly prescribed medications for one illness, or interacting medications. And of course, that's where the pharmacist really has to step in. We step in to make sure that we address that concern and stop any sort of side effects from getting worse or happening in that patient.
Yeah, for sure. Having that interdisciplinary communication is key. It allows us to make sure that we're all on the same page. And I think it's important, especially on behalf of the patients and the people who are suffering. There's definitely some really cool softwares and movements that are actually focusing on pushing more interdisciplinary communication. I find that it's really more of like a new age the newer generation of healthcare professionals such as us who are focusing on like, listen, we got to talk to each other in order for us to be able to provide the best care. Now that's one aspect of the matter. Let's talk about like from a patient's and like the listener standpoint, right? What are some of like one or two things that you think are the most useful actions? And I didn't give you this question beforehand because it just occurred to me, but what are the one or two most actionable things that patients can do to advocate for themselves in regards to just getting a better understanding of like medications and everything? Because there's definitely a lot of things to consider, like perhaps the multiple different physicians haven't maybe missed a couple of medications and then you're there, but then also it's like, what can patients do to really maximize their advocacy throughout this process?
Sure. What they can do, you could start off with making a list of all medications that you might have in your house, in your medicine cabinet, things that you're actively taking, list it down, write down the strength, write down how often you're supposed to be taking it, and also write down any sort of vitamins and supplements that you're taking too, because you never know that there might be an interaction. The next step I do is take that list and try to get an appointment or speak to your pharmacist. That's like the first way to figure out if there's a true drug interaction, because of course we're sort of the masters of drug interactions and anything to do with the medications. So we could like be the first line of defense for patients to be like, don't take in, once we consult with the physicians, we can advise the patient to be like, don't take that anymore, continue taking this other medication. But of course you can start off with going to the pharmacist first. Definitely meet with them. They can do something called a comprehensive medication review, a CMR, if you'd like, if they do offer that at your local pharmacy. So essentially they might ask you to bring all your medications that you take, bring it into the pharmacy with you. And then what I usually do with my patients is I'll look at every single medication, write it down, and then I'll also ask them, do you know why you're taking, metformin? And if they can answer it correctly, then it's good. If they can't answer why they're taking a certain medication, then you question, are they really supposed to be taking that medication, or is there not enough education for them to take it? So really figure out, whenever you're getting a new medication, ask those questions at the counter. Why am I taking this medication? Ask about side effects. Don't be in a rush to leave the pharmacy counter when you're checking out with the new medication that you might have questions about. We're here to always answer all your questions and such. And if you have any concerns, we're here to address them. So definitely, in order to advocate for your own health, definitely play a huge part in that. So that's my advice.
Huge. Talk to your pharmacist, ask questions, write it all down. That's allows you to keep track of a whole bunch of different things, which also it's important, especially if you're dealing with pain for a long period of time. Obviously, definitely record your medications, but also a really useful tool for you listeners to help you understand how your pain is actually behaving. Keeping something as simple as a pain journal is going to be really important. And that way you can write, at this time I felt pain. And as you are mapping out your pain journey, we can identify what your triggers are and also the activities that will bring your pain down. It gives us more information, and no new detail is too minute. Sonny, this was extremely eye-opening. I learned a ton, and I also think that the listeners have as well. For the listeners out there who want to get in touch with you, I know that you also do pharmacogenomics. Tell us a little bit more about that and how people can get in touch with you.
Yeah, sure. If you want to reach out to me, I have a website right now. It's Dr. Sonny, Sonny, Shah, Shah.com. That's my website. If you go right now, it's in its preliminary phases. And you can reach out to me also on Threads and on Instagram, also Dr. Sonny Shah. So with pharmacogenomics, what we're finding out that since I think the last 10, 15 years, they finally mapped most or of all, if not all, the human genome. And we're figuring out what sorts of parts of your DNA influence how your body reacts to medications. Most of the time, your body relies on your liver. Like I had mentioned before, your liver is the main point of metabolism. And there are these proteins. I'm just going to go very scientific. And if you have any questions, you can always ask me. But there are these CYP proteins in the liver that are enzymes that break down certain medications. And if you have a certain type of genetic sequence, if you have a certain type of DNA, you might not be able to break down certain medications. So that's very important. So what that might present as is if you you start a new medication, like let's just give a really good example, Plavix or clopidogrel. It's a common blood thinning medication given to patients post heart attacks or strokes. It's a prodrug, so it relies on your liver to be metabolized into its active form, but there's a subset of the population that actually cannot metabolize it to its active form. So in those cases, you're going to have patients that have repeat heart attacks, stroke, and we've unfortunately seen that. But these pharmacogenomics testing, we can figure that out ahead of time and get it to your cardiologist if you have one, or even your general practitioner, and they know which drugs to avoid prescribing and which ones to actually prescribe for you. And that's just like it in a nutshell. If you want more info, definitely stop by my social and my website. Yep.
Absolutely. Listeners, if you didn't get a chance to write that down, I'm actually going to be putting his contact information into the show notes. So yeah, you'd want to be able to look at how your genes play into your drug interactions. Dr. Sonny Shah is the person to go to. Sonny, thank you so much for your time and your expertise.
No, thanks for having me, Ashley. This was great. And this is my first time on a podcast, so thanks for helping me out.
Absolutely. Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day. No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.